In microscopic urine examination, stains are used to enhance visualization. Sternheimer-Malbin is the most frequently used supravital stain. Sudan 3 and oil red O are used to confirm the presence of fat or triglycerides. Normal urine may contain up to 2 red blood cells per high power field, up to 5 white blood cells per high power field, and up to 2 hyaline or fine granular casts per low power field. A few epithelial cells and slight mucus may also be present, and these findings are generally considered normal. Red blood cells in urine may indicate glomerular damage or menstrual contamination. They can be altered by pH and osmotic pressure, forming ghost cells, crenated cells, or swollen cells. They may also be mistaken for yeast cells or oil droplets, but adding 2% acetic acid will lyse red blood cells and help distinguish them. White blood cells in urine may indicate inflammation or infection, a condition known as pyuria. Casts are cylindrical structures with parallel sides. They form in the lumen of the distal convoluted tubule and collecting duct. Their main constituent is uromodulin, formerly known as Tam-Horsfall protein, a glycoprotein secreted by renal tubular epithelial cells. Cast formation is influenced by urine pH, flow rate, solute concentration, and the presence of protein. Hyaline casts are the most frequently seen and are composed primarily of uromodulin protein. Red cell casts indicate bleeding from the nephron and glomerular dysfunction. They appear as tightly packed red blood cells with an orange-red color in unstained sediment, and they are diagnostic of intrinsic renal disease such as glomerulonephritis. White cell casts signify infection or inflammation within the nephron and are typically associated with pyelonephritis. Granular casts represent disintegration of cellular casts. Waxy casts are an advanced stage of hyaline, granular, or cellular casts and indicate prolonged urinary stasis, as seen in chronic renal disease. They are often referred to as renal failure casts. Fatty casts form when epithelial cell casts break down and contain oval fat bodies. Broad casts are formed in dilated collecting ducts and are a poor prognostic sign. Any type of cast may appear as a broad cast. Red blood cells in urine can be recognized physically by turbidity and a red color. Chemically, they correlate with the presence of blood. White blood cells add turbidity to urine as well, and their chemical correlations include protein, nitrite, and leukocyte esterase. Epithelial cells are noted for causing turbidity in urine. Chemically, they are associated with protein findings. Casts, which also contribute to turbidity, are similarly linked to protein in chemical testing. Bacteria in urine contribute to turbidity and correlate chemically with pH changes, nitrite positivity, and leukocyte esterase. Crystals, which also produce turbidity, have their strongest chemical correlation with urine pH. Squamous epithelial cells are the largest cells found in urine. They have abundant irregular cytoplasm and a central nucleus about the size of a red blood cell. These cells are the least significant clinically but are the most frequently seen. They usually originate from the vaginal lining or the lower urethra. Transitional epithelial cells are round or pear-shaped with a central nucleus. They have the ability to absorb water and may swell to as much as 3 times their normal size. These cells may indicate renal carcinoma and are normally found in the renal pelvis, bladder, or upper urethra. Their numbers increase with catheterization. Renal tubular epithelial cells are the most significant of the epithelial cells found in urine. They are round, have an eccentric nucleus, and are larger than white blood cells. Their presence is strongly associated with tubular necrosis as they originate from the renal tubules. Oval fat bodies are renal tubular epithelial cells that contain highly refractile fat droplets. They are commonly seen in nephrotic syndrome. Under polarized light, they display a Maltese cross pattern. They can be confirmed with fat stains such as Sudan 3 or oil red O. Crystals are formed when urine solutes precipitate due to changes in pH, temperature, or concentration. In acidic urine, you may find amorphous urites, which appear as yellow-brown granules or pink sediment. Uric acid crystals take on a variety of shapes, usually yellow rhomboids. Calcium oxalate crystals appear envelope-shaped and may be seen in cases of antifreeze poisoning, especially in young children. In alkaline urine, amorphous phosphates form as a white precipitate and are microscopically identical to amorphous urites. Triple phosphate crystals resemble coffin lids, ammonium biurate crystals appear as thorn apples, and calcium carbonate crystals resemble dumbbells. Abnormal crystals often indicate metabolic disorders or the presence of drug metabolites. Bilirubin forms small clusters of yellow-brown fine needles. Cysteine crystals appear as colorless hexagonal plates. Cholesterol forms rectangular plates with notched corners. Leucine crystals are yellow-brown spheres with concentric circles or radial striations. Tyrosine crystals appear as colorless needles, and when seen with leucine crystals, they suggest liver disease. Sulfonamide drugs may form needles or brown spheres. Radiographic dye can precipitate as plates, and ampicillin may crystallize as needles. Bacteria, particularly rod-shaped bacilli, are the most commonly seen organisms and should be correlated with leukocytes. Yeast is often associated with vaginal infection and must be confirmed with clinical findings. Parasites such as Trichomonas vaginalis or Enterobius vermicularis may also be detected. Sperm can occasionally be seen in both males and females. Mucus may appear but is of no clinical significance. Clue cells, which are squamous epithelial cells with bacteria adhering to their surface, indicate bacterial vaginosis. In some viral infections, such as rubella or herpes, renal tubular epithelial cells may contain inclusion bodies. Cytomegalovirus, or CMV, produces large intranuclear inclusions. Lead poisoning results in cytoplasmic inclusions, which can be visualized using a cytocentrifuge and Papanicolaou stain. Hemosiderin, a form of iron, may be found in renal tubular cells or urine sediment and suggests severe intravascular hemolysis. Paroxysmal cold hemoglobinuria, or hemochromatosis. Hemosiderin can be confirmed with a cytocentrifuge preparation and Prussian blue staining. Powder artifacts, such as starch granules from gloves, may be mistaken for crystals. Under polarized light, they can produce a Maltese cross formation, but unlike cholesterol crystals, they are not round in shape. Fat artifacts can also appear in urine microscopy. Triglycerides will stain positive with fat stains. Cholesterol, on the other hand, does not stain, but under polarized light it produces a Maltese cross appearance. Hair fibers may be confused with casts due to their elongated shape. True fibers, however, can be distinguished because they polarize light, whereas casts do not. In acute glomerulonephritis, urine often shows gross hematuria with a smoky turbidity. Red blood cell casts are a hallmark finding. Chronic glomerulonephritis is also associated with hematuria. A variety of casts may be seen, although red blood cell casts are only occasional or few in number. Waxy casts are often present as well. Acute pyelonephritis produces turbid urine. Laboratory findings include a positive nitrite test, a positive leukocyte esterase, white blood cell casts, and the presence of bacteria. Chronic pyelonephritis shows similar results, with positive nitrite and leukocyte esterase. All types of casts can appear, but usually only occasional to few white blood cell casts are found. In nephrotic syndrome, microscopic examination may reveal free fat droplets, fatty casts, and oval fat bodies. These findings are strongly associated with heavy proteinuria and lipid abnormalities. In cystitis and lower urinary tract infections, urine often contains bacteria along with white blood cells, confirming infection.